Hello viewers, welcome to my channel. How to address hypothyroidism. This topic was presented by Dr. Shahnoor Sharmin, who is working as an associate professor at Dhaka Medical College Hospital in the Department of Medicine, and it was presented on the occasion of continuous professional development program arranged by Bangladesh College of Physicians and Surgeons. Hypothyroidism is a clinical syndrome resulting from a deficiency of thyroid hormones, which in turn results in generalized slowing down of metabolic process. Now, hypothyroidism Bangladesh perspective. The actual burden of thyroid dysfunction in Bangladesh is largely unknown, though it is believed that 20% of general population is suffering from any thyroid disorder. A cross-sectional study conducted from April 2008 to March 2009 in Dhaka city over a total of 289 individuals showed that thyroid dysfunction was found in 10.03% individuals. Of them, 3.46% had subclinical hypothyroidism and 3.8% had hypothyroidism. Etiologically, hypothyroidism may be primary hypothyroidism, which may be due to autoimmune causes, iatrogenic causes, it may be transient, may be due to iodine deficiency, may be congenital or infiltrative. Secondary hypothyroidism is due to pituitary adenoma, pituitary ablative therapy, and pituitary destruction. Tertiary hypothyroidism is due to hypothalamic dysfunction, which is rare. In some cases, there is peripheral resistance to the action of thyroid hormone. This picture showing some signs symptoms of hypothyroidism. Generally, the patient presents with fatigue, feeling of cold, weight gain with poor appetite. Patient may experience hair loss. There may be shortness of breath. His skin may show paresthesia or myxodermatous changes. He or she may complain of constipation and menstrual abnormality like menorrhagia. Psychologically, patient may have poor memory and concentration, his hearing may be impaired, he may experience hoarseness of voice. On examination, we can find that the patient is having bradycardia and his muscle reflex has delayed reflex relaxation. The extremities may be found cold and carpal tunnel syndrome may be present. So, how to diagnose hypothyroidism? The combination of low serum free T4 and elevated serum TSH is diagnostic of primary hypothyroidism. Serum T3 levels are variable and may be within the normal range. A positive test for thyroid autoantibodies suggests underlying Hashimoto's thyroiditis. ECG abnormalities in the form of sinus bradycardia, low voltage complex, HTT change, and severe and prolonged hypothyroidism. Some non-specific laboratory findings may be present. This is a picture showing an approach to adults with suspected primary hypothyroidism. Now, coming to the management aspect of hypothyroidism, most patients require lifelong treatment. The goals of treatment are restoration of euthyroid state, reversal of signs and symptoms, prevention of complications, and reduction of goiter. The treatment is done with levothyroxine replacement. It is a growth hormone of which 80% are absorbed. It has a long half-life of 7 days. It should be taken in an empty stomach. Morning dose is preferred because it can cause insomnia if taken at night. Replacement dose of levothyroxine in adult ranges from 0.05 to zero point 0.2 mg per day, or it can also be calculated as 1 to 2 microgram per kg per day. In younger patients, it is safe to initiate levothyroxine at a higher dose. The dose of levothyroxine should be adjusted to maintain serum TSH within the reference range. Patient feels better within 2 to 3 weeks. Clinical and biochemical evaluations at 6 to 8 week interval is required until the serum TSH concentration is normalized. It is important to measure thyroid function every 1 to 2 years. When monitoring serum thyroxine level, it is better to draw the fasting blood or before taking the morning dose to obtain consistent data. In some cases, there is a requirement for additional dose adjustment, and increased dose is necessary in pregnancy, patients who are being treated with estrogen, who are co-administered with other drugs, and after surgical or radioiodine ablation of Graves' disease. Decreased dose is necessary in elderly patients, patients with marked weight loss, and patients who are being treated with androgen therapy. Now, we face some problems during our treatment of hypothyroidism. We may find that the serum TSH level is persistently elevated despite apparently adequate replacement dose of levothyroxine. Patient may present with high serum TSH and T4 level. Sometimes symptoms of hypothyroidism may be present with normal thyroid function tests. Subclinical hypothyroidism cases may be found that is raised serum TSH with T3 and T4 are at lower end of the reference range. Non-thyroidal illness or sick euthyroidism may be found, and in this case we will find low serum TSH, raised T4 and normal or low T3. Myxedema coma is an end stage of untreated hypothyroidism commonly found in older age group. Levothyroxine therapy can exacerbate myocardial ischemia. Patients can be presented with severe depression, sometimes may be confused, paranoid, even become manic, which is known as myxedema madness. Now, what are the toxic effects of levothyroxine therapy? Actually, there is no reported allergy to pure levothyroxine. Toxic effects of levothyroxine is like hyperthyroidism may present with arrhythmia. Overtreatment with levothyroxine can cause increased bone resorption and osteoporosis. So, while treating a patient with hypothyroidism, some points should be kept in mind. Hypothyroidism usually presents with non-specific symptoms. It is more common in women. Subclinical hypothyroidism may progress to overt hypothyroidism. In most cases, lifelong therapy is needed. Regular follow-up is mandatory. Cautions must be taken in elderly patients, especially with ischemic heart disease. Thank you for watching. Goodbye.